My name's Peter Schneider, and I have with me two experts, Dr. Mitri Khoury, vascular surgeon, Dr. Jon Faiwiszewski, interventional cardiologist. And we are going to spend the next little while, somewhat less than an hour, just mainly talking cases and talking about interesting opportunities. And one of them, of course, being the use of the serration angioplasty balloon or the Serranator. So there have been a lot of fun things it's kind of fun over the weekend. I got a couple of different texts, one from a buddy who was using Serranator to do the crossover from artery to vein on a limb flow case, and another one who was kind of using it in the foot for the first time, which was pretty gratifying. In any event, we'll go ahead and get started. And I think what we'll do, both Mitri and Jon are going to show some cases. We will start with the inevitable couple of slides here as an intro to Serranator and use of the Serranator. So this is a concept I've been familiar with for quite some time, but now as the use of it grows and as the interest in it grows, we have now more sizes, more lengths, more diameters, and people are finding all kinds of interesting uses. I just mentioned two of them. We didn't start out thinking, oh, we needed to upgrade pedal angioplasty, but it turns out to be a pretty good upgrade to that procedure. So we have the Serranator in 2.5 through 6, and then the 7s and 8s now are going to come out. This would be external iliac, common femoral, etc. Those are coming out in the fall. So that'll be a lot of fun when that's available. And then recently, just a few months ago, we launched a 2.0 SL Pro, which has become a go-to for common plantar, medial and lateral plantar, distal AT, DP, that kind of thing. So that's been a lot of fun. And of course, the concept is that the Serranator or serration angioplasty balloon has a series of spikes or a series of metal flanges on the outside of the balloon. Each one pokes a hole. And here's the physics. And you can see what some other modified balloons look like when you do the math of the tip of the element pointing into the artery. You can see that you get an appreciable improvement or increase with standard modified balloons with a wire on the outside of the balloon. You see that you can get up to a 22x on what a standard balloon can provide. But with the Serranator, it's actually dramatically increased. And although I'm not a physicist, I do understand that if my lovely wife steps on my foot with a pair of Nikes, that's really different than if she steps on my foot with a pair of stiletto heels. So, and that's really essentially the same principle. And we like to call it point force, or there's so much focal force, but it's delivered at a point. So this allows a dramatic increase in what an otherwise innocent looking balloon can deliver. And you can see kind of in this stylized rendition what's happening here. Each element or each flange or spike is pointing into the wall. Each one is causing some cracks in the calcium. And as a group, they form a serration, just like you have, opening a FedEx package or a box of crackers or anything like that. You always have a serration that allows you to direct the energy that you're applying along a specific line. And even though the plaque is incredibly heterogeneous, the potential then for that direction of energy to be delivered is it tends to result in an excellent delivery of the energy along a specific line, and that allows a relief or a release of the plaque. So in terms of where can we go with this, or what have we learned so far? Well, we have learned that lumen gain can be optimized in this way with a very low risk. These are tibial numbers now, very low rate of CDTLR at 6 months, a low rate of recoil, and I'm going to go into that a little bit. Recoil is one of those things that everyone talks about, but nobody does anything about. And now we have the ability to mitigate recoil with serranation or serration angioplasty. And of course, with that, with the ability to direct the energy along a specific line, you get fewer severe vessel wall defects or dissections. So in this concept of acute lumen gain, we had a nice study that was conducted by Marianne Brodmann, who everyone knows, who's the head of angiology at Graz, Austria, home of Arnold Schwarzenegger. That's the way I always remember Graz. And what she looked at was the type of lumen gain you get with a plain balloon versus the type of lumen gain that you get with Serranator. And what she found was that in core lab adjudicated studies of plain balloon angioplasty, very often the residual stenosis was right up around 28 to 30%, almost right up at where we would say it's not going to be an acceptable result, whereas the residual stenosis with Serranator was in the range of 20 to 22%. So a dramatic decrease in residual stenosis. If you do the math, radius to the fourth power, that's an increase in flow in that segment. So then I mentioned the decrease in residual stenosis, but that all comes at what I would say is a relatively low pressure. A typical plain balloon case below the knee, you're frequently going to hit 8, 10, 12 atmospheres sometimes. And the average in that study using Serranator was 5 atmospheres. The recoil study, the PI was Vanita Chandra from Stanford, who I think all of you will know. And also Michael Lichtenberg's site in Arnsberg, Germany was involved. And you know about recoil in the sense that this is a much heralded problem that we just sort of feel like we have to accept. And that is, and I've had this many times where I've done one tibial, maybe done a post-tib, and then gone on to treat the AT. And once I got that open, I did a completion angio and found that my original work in the PT now was suffering from recoil, which is, I think, an exacerbation of the kind of the wall, the muscular response of the wall of the artery. And in this study, of recoil, these were, again, all BTK cases. It was a comparison of Serranator and plain balloon. And Serranator had an average recoil or mean recoil across all lesions at 15 minutes after the last angioplasty of 6%, whereas with plain balloon, it was 55%. And just worth mentioning one other thing, and that is in the original sort of classic seminal tibial recoil paper by Baumgartner, published back in the mid-teens, he used plain balloon and found a 97% recoil rate. But keep in mind that our balloon protocol has improved since the mid-teens. Over these last 10 years, we know we have to do proper sizing, gradual inflation. We know that we have to do prolonged inflation. So we followed a modern plain balloon protocol, and the recoil rate did go down from that original seminal paper from 97% to 55%, but it was still pretty dramatic and pretty high compared to that which we found with Serranator. So average recoil 6% versus 55%. So I'm going to stop sharing now, and I'm going to invite Dr. Khoury, Mitri Khoury, to show his slides. And while he is sort of getting his slides on board, let me just say that please use the chat. We'd love to entertain any questions you may have. We're happy to entertain questions even during the presentations and, of course, afterward. And we're looking forward to a robust discussion.
Awesome. Yeah, thank you everyone for having me. I'm excited to be here. Yeah, I just want to highlight 3 cases where I thought this balloon worked really, really well. So the first case, this was a 69-year-old male, essentially presenting to the emergency room with breast pain. And he had a prior left iliac stent, SFA stent done at an outside hospital, no prior abdominal surgeries, and of note, he had a recent PCI placed, probably I think it was like a month before this, on aspirin Plavix, and he was on statin. And these were his lower extremity non-invasive studies. As you can see here, reduction in the ABIs and the PVR waveform, especially the level of the toe. And so this is just to kind of highlight the iliac stent that he had. This is a CTA. And as we come down, large IMA there, his right iliac system is completely occluded. And then he has this left iliac stent that's kind of floating in the aorta and floating a little bit in the iliac system there. And then as we come down, you can see that his SFA stent is completely occluded. You can keep coming down, and it reconstitutes at the pop. So, started him on a heparin drip in the hospital. Symptoms supposedly got better. I booked him for a left lower extremity angiogram via radial approach with the patient left AMA. Shows up to my clinic 2 weeks later saying that his foot, still really hurts. Booked him again for an angiogram. He again cancels the appointment. And again, booked him again for an angiogram. And then this is how he showed up in the pre-op area. So now he's converted to tissue loss. So I performed the left lower extremity angiogram via radial access, but I was not able to cross from above. So, the next options I thought, antegrade femoral access, pedal access, or do I go straight to a bypass?
Hey, Dr. Khoury, could you go into use the slide show mode? Yeah. I think because it would help us to see a larger, maybe.
Oh, I see. Okay. Is that better?
Nice. Yes.
Okay.
Yeah, that's great. Thanks.
Yeah. So this perfect guy, yeah. So basically, he converted now to tissue loss, and I wasn't able to cross from the SFA from above. He's a larger guy. I could do antegrade femoral access. I don't particularly like doing antegrade femoral access on, patients that are obese. I find it particularly difficult. But his GSV was not of adequate caliber, so I decided to do pedal access for this guy. So left posterior tibial artery was accessed. Put a 6 French slender sheath. I was able to cross the SFA lesion to the aorta. And I didn't have his preoperative record, so I like to especially use IVUS in these cases to make sure, one, I'm in the true lumen and identify any lesions that I'm not seeing on angiogram. Of note, I did see a lesion just distal to the prior stent, which is probably why he had stent failure. I performed atherectomy for the in-stent occlusion, and then I used a 6 millimeter Serranator followed by a 6 millimeter drug-eluting stent, and this was all sized via IVUS, and then post-dilated with a 6 millimeter balloon. And as you can see here, we got a good, nice angiographic result. The SFA revascularized pretty well. And this was him a few months later, so completely healed. We have, excellent wound care teams in podiatry that work with us. And so they did a really good job with him being patient and getting this guy through. So this was a nice case. I find, especially with, in-stent stenosis with intimal hyperplasia, I definitely like to treat these patients with the Serranator because I think it gets into the intimal hyperplasia really well and gets really good drug delivery. So here's a second case of mine. This is a 40-year-old male referred to me due to non-healing toe amputation sites. You can see here, not really significant past medical history, but he does have an A1C of 12.2. And then you can see here, his ABIs aren't too bad. So this is mostly like really distal tibial or, digital artery disease. So I went angiogram via contralateral femoral access, and he's found to have an occlusive PT. And, I was unable to cross it at that time. And I know he's obese, but, it was most of this stuff was distal tibial, and there's no way I was going to get to it via radial. So I was forced to do antegrade access on this guy. I tried doing with a POVA, but I got a lot, still not healing. He had weeks of wound care, just not really working. So then I took him back for another angiogram, and I noted that the PT is occluded again. So then we utilized a 2.5 millimeter Serranator balloon. And then, so this is kind of what we had here. As you can see here, this distal PT is completely occluded. Recalcitrant lesion, and then we treated with Serranator. We got a good angiographic result, and then I didn't show it here. We had a nice wound blush on the angiogram. This is him now. Still has some fibrinous tissue. We probably need to do a little bit more work, but now he's finally starting to get some granulation tissue. So it's a nice example of like recalcitrant lesions. This balloon, starting to work really well.
That's a great case. Let me just ask you, if you don't mind, when you have somebody with a challenging antegrade, and they and maybe it's a body habitus issue, but we really like to go antegrade because the lesion is all the way down at the ankle. Have you used at all proximal SFA as a as an access site?
Oh yeah,
Um,
yeah, I have done that. Especially what I do is I go under ultrasound and I see if I can compress it. So if it's easily compressible, I usually go for it. Or if the
yeah,
artery is good caliber, I'll stick it and you know, even try closure devices.
yeah, yeah. I agree, and I think sometimes the people with the large body habitus, they don't always have a huge thigh to go with it. Sometimes the thigh is rather trim, and it's and it can be used. I do think the more proximal in the SFA you go, the better.
Yeah,
At least in my experience. I think also if the SFA is, if it's small, don't bother. If you have at least a 5, but hopefully more like a 6 on ultrasound, then I think maybe a closure would work there. But yeah, that I think that's a nice technique. And then I also wanted to ask you both, maybe. So that lesion you showed, so it's at the ankle, so it's distal PT, it's going into the common plantar. I didn't quite see if it looked like it reconstituted both the medial and lateral plantar. What's your crossing strategy, Mitri, for a lesion like that? How far down do you put the sheath? What wire do you use?
yeah.
What's
I
your
mean,
kind of general list of things you like to do?
yeah, I like to park the sheath in the pop if I can. You know, I think if we can get getting the sheath as far down as possible is key because then you get your pushability. And then usually I use a combination of 018, 014 wires to try and cross these lesions. Usually I'm pulling like at least three off the shelf. And Ebru, my Serranator rep really helps me out in these cases because she knows which wires I would like to use. But these are, you know, these can be challenging cases. So I think you're setting up your platform correctly is just the right way to go.
Yeah, yeah, great. John, anything to add to that?
Yeah, so a couple of things. First of all, to comment on direct SFA access, I have started doing all of my vascular closure under direct ultrasound. It's something that somebody else gave me an idea. And when I started using the KELT device, where it used to be that it was taught that you use the KELT to close under direct ultrasound visualization, I just got comfortable doing it. And now I even use it for percloses and angioseals and whatever else. And so what I would say with regards to antegrade access is for a long time, I felt like, as a fellow doing antegrade access, that the closure was a coin flip if you were going to get a reasonable result or if it was going to turn into a manual hold. And since I've been doing direct ultrasound visualization for closure, even with something like a per close, I'm able to get very consistent, reliable closure with integrate sticks. And so it has opened up the possibility of using the proximal SFA as an access site because I do feel like I'm able to get pretty consistent and reliable hemostasis at the end of the case. So one thing we might even think about doing, even as a group, as people on the call, is to maybe have a registry where we do, ultrasound versus traditional closure for integrate sticks. And I bet you that probably we'd find as a group that that's a reliable way to get hemostasis for our access sites.
And then
Um,
when you talk about that, are you also using ultrasound to put, say, not just to look at the integrity of the closure, but to put pressure, ultrasound guided pressure for a few minutes, or how do you work that? Or
Yeah, so in the example of the perclose, I'm able to visualize the anterior and posterior walls. I'm able to visualize any plaque that's there, and I hold the ultrasound probe in the long axis view, so I can see where the footplate is deploying, and I can make sure that the footplate is not deploying in, let's say, posterior wall plaque, that it's not deploying in the wall, and that I'm really flush against that anterior wall. I even watch the needles plunge in real time, so I'm very confident where the sutures are deploying. And then for the KELT device, it's a very similar experience.
yeah, yeah.
That's a really,
Uh,
yeah, I like
yeah.
that.
Go ahead.
No, I
Mitri,
was
go
saying,
ahead.
I was just commenting. That's a good. I have not seen anyone do that. I think that's a really good idea.
Yeah, that's pretty cool. Now we do have a question from one of the attendees looking at what's your algorithm for long tibial CTOs? And this is Dr. Naeem, and he is talking about a lesion longer than 10 cm, but of course could be from 10 cm to unlimited, qualifies as long. How do you, anything that you can add to what you said about crossing tibial occlusions for a long lesion?
Yeah, sometimes I sometimes think that pedal access is a lot easier in these cases. I feel like you obviously get a better idea of like how the cap morphology looks on angiogram. I feel like with these longer tibial occlusions, that pedal access tends to be a little bit easier. Obviously, you need to make sure that it's open distally to get something to cross into, but that's what I find to be the easiest. And then once you get into it, sometimes it is hard to track stuff through. So sometimes even like doing like a laser atherectomy or something like that to help debulk the lesion also, I find it to be useful. I find atherectomy to be more useful in the tibials than anywhere else. I don't know how other people feel.
Yeah.
Yeah, so I would second everything that you said. Personally, my threshold to go retro is very low. I spend maybe 5 to 10 minutes trying to cross antegrade. If things are going smoothly, fantastic. I'll stick with the antegrade approach. As long as there's a reasonable open vessel down at the ankle. Again, I think that with good ultrasound skills, we can reliably get into these vessels without banging them up or dissecting them. The retrograde crossing is typically much easier. Something I learned from John Laird is to really avoid pushing looped wires because that's how you get, deep wall dissections and big planes that are very hard to come back from. So one thing that I would say is if you're new to doing CLI work, be really patient with your wire manipulation. Really try to keep a straight wire and torque it back and forth and use something like maybe an 014 or an 018 support catheter to make sure that you're able to keep things pointed in the direction you want to go. If all that fails, then cart and reverse cart usually will work. Some combination of antegrade, retrograde, and a small like 5 millimeter balloon, you can typically get these things to connect.
Yeah, agreed. And I think, and you both said it, I mean, the longer the lesion, the more likely you're going to need bidirectional access,
Yeah.
which in a tibial, that means a pedal or ankle puncture. So, Dr. Mitri, why don't you go ahead with your next case? Sorry to see what happens. We get talking about something, and the next thing you know.
Yeah, it's a great discussion. Let's see here. Yeah, so this is my last case here. I just kind of wanted to highlight. So this is a 55-year-old male presenting with tissue loss. You can see here, these are some of the lower extremity non-invasive studies that they got. They weren't able to get ABIs because they weren't able to compress them. And so he had right lower extremity angiogram via contralateral femoral access. Lesion was crossed, eventually exchanged it for an 014. And again, I use a lot of IVUS for sizing. And so, I think this lesion shows how well that Serranator does. And so this was a 7 millimeter chosen followed by a DCB. And that's sort of my algorithm. I don't just do POVA by itself anymore. Usually, and I like Serranator because I think it does really well with DCB. And this is angiogram was done 10 minutes after the original treatment. So I've been tending to do that just because with the people have described here, they've been having issues with recalcitrant lesions or recoil. And this is just a nice example of a lesion that's continued to stay open. So I felt pretty confident that this was going to stay open. And now, this guy has healed his wound. So I think that's another thing that I've been doing is, doing delayed angiograms to make sure things don't shut back down. And this is just a great case of how Serranator was able to keep things open.
And without metal.
And without metal, that's right.
Yeah, that makes sense. And let's see, Mitri, why don't you stop sharing? And John, why don't you bring yours up? And while you're doing that, let me another part of that question that I asked before about the long CTOs is what's the role of Serranator in long tibial CTOs? A couple of people are asking about that. I don't know, Mitri, what do you think? Do you have Serranator and long CTOs?
I mean, I use this balloon pretty regularly. I mean, so I use it. I use it for long CTOs. I mean, sometimes you have to pre-treat to get it to cross. with like a smaller POBA balloon. But other than that, I typically use it because like I said, the recoil is pretty good, and I feel like tibials tend to recoil more than any other sort of like versus the femoral popliteal lesions. So I tend to be pretty aggressive with Serranator, especially in CTOs. The one thing is I use IVUS a lot. Like you can see you just have to make sure that you're not like an intimal, like subintimal plane or something like that. I think it's just important to do that before you start treating.
Yeah. John,
To add to
anything?
that, yeah, I would say that, for those of us who do CLI work, one thing that we probably have all experienced, which is really frustrating, is you spend a long time crossing a really hard long lesion. You struggle with device delivery. Finally, you get the laser catheter to go down, and finally you get your balloon, and you get an okayish result at the end of the procedure, and then the patient comes back reoccluded within a couple of weeks, and it's incredibly frustrating. Since we've been using the Serranator, it just feels like that doesn't really happen nearly as much anymore. It just feels like for the very first time, we have something that works in the tibials as a true destination device. Um, I think that we all have been hearing predominantly, I would say, from Abbott about using, the bioresorbable scaffold as a destination therapy, the same way that, historically in the coronary space, the balloon was not the end result of the treatment, it was the stent. And, I think certain companies want bioresorbable scaffold to be that thing that we reach for in the tibials. But in my hands and in my experience, and I think some of us feel the same way, the Serranator gets you that result and you leave nothing behind. So with
Gotcha.
that,
Yeah.
I'll get started on these cases, and I'll let you know that I have 5 prepared, and that will probably take us past the hour. So I will stop as soon as we hit the hour. But hopefully we'll be able to generate some discussion. So my first case is a really tricky gal. She's 58 years old. She's from a very indigent population that I used to take care of in California. Lots of smoking and meth use. She's diabetic. She's got advanced CKD. She previously had multiple interventions on her left leg, and this was before we had the Serranator, and ultimately she ended up with a below knee amputation. And now she's coming back with this wound on her right heel, and she's really hoping that she can avoid becoming a double amputee. Fortunately, now we do have the Serranator, and that's going to change our ability to handle some of her CLI. And what we find is, and this is not uncommon in these folks, the inflow is relatively normal. There's a little disease in the aorta, very minimal plaquing in the iliac system. The SFA looks really quite healthy. And then once you get down below the knee, we see really quite a disaster. So she's got an occluded AT, occluded PT, and a very severe lesion in the perineal artery. And when you take the angiogram of the foot, there's just not a lot of filling there. This is, a still frame of the angiogram, but this is staying on the cine pedal for a very long time. So we start off by coming antegrade, try to get into that AT. We do it under digital subtraction roadmap, and we find that it's a fairly short occlusion, but despite my best efforts, I did get subintimal. You can see that wire tip just outside of where that reconstitution is. As I mentioned, I have a very low threshold for coming retrograde. She has a reasonably normal looking AT down at the ankle. Able to do a little bit of reverse cart with a 2 mm balloon, and able to get that wire externalized, switch directions, 1.4 mm spectronetics laser followed by a 3.5 mm Serranator. That was based on IVUS sizing, so that was not arbitrary. And repeat the angiogram, and the AT looks fantastic. And I'm going to keep going. So every subsequent angiogram that you see is a delayed angiogram. In this case, we were able to stick with that antegrade approach, actually came through the pedal loop and up the posterior tib, crossing the PT occlusion from the retrograde. Again, I did not have to stick the PT, I just came directly through the loop. We're then able to externalize the wire and reverse the direction again. Same 1.4 mm laser, same 3.5 mm Serranator, and we have a beautiful result on that PT. You see that AT still looks really good, and this is 20-30 minutes later. And then it was pretty quick work to handle that PT, since it was pretty much just 95-ish% occluded, and the final result looks like a complete revascularization of the foot, and we were very happy with that. So, case in point, with a little time and a little bit of, attention to detail, you can get a nice complete revascularization that's quite durable with just a laser and a Serranator balloon.
That was a beautiful case. And it was really nice how you used that, the access and recanalization to the AT to then do another type of bidirectional approach going through the pedal loop to get the PT. And I was surprised when you were first presenting, I thought, why is he going after the AT? It's the PT he's going to need to open. And of course, in a case like this with a horrible foot, you're probably going to open everything you can possibly open. At least that's kind of what I would be thinking. So, and is that kind of your approach as well?
Yeah, I definitely pay attention to the woundosome first and foremost, but I think you take what you get. Sometimes you get the woundosome vessel open, and sometimes you get something else, and you hope that even by increasing the pressure head to collaterals, that might be enough to get the leg out of trouble. And very often, I might not get the woundosome vessel open and see how the patient does. And if I bring them back a week or two later because they're not healing sufficiently, then I know what I have to really focus my energy on.
Yeah, the calcaneal branches here look really good, and hopefully they'll deliver plenty of flow to that heel.
Yeah,
It's a beautiful result.
thank you. So we'll go on to another patient. This is a 72-year-old gal who's been having left foot pain and redness, and she's been on antibiotics for cellulitis multiple times. She now is progressing to rest pain, which landed her in the emergency department. She had a stat duplex that was done, which shows abnormal excuse me, abnormal flow in the common femoral, suggesting inflow disease, and then monophasic waveforms pretty much throughout the leg below that. She then had a CT angio, which does suggest that she has inflow disease as well. This is what her leg looked like, which is a very typical presentation for dependent rubor. I don't have a picture, but you elevate this leg and it blanches if you lift it up, above the heart, and then you put it back down and it turns red again. So we brought her in for an angiogram. Very severely diseased abdominal aorta. Both iliac systems are very severely diseased. She's missing both internal iliacs, which is a common place for source of collateral. So she's not going to have as robust collaterals as somebody else might. And then you see diffuse disease of the SFA. There is an occlusion in the mid vessel. There is a brief reconstitution in Hunter's canal, and then P1 into P2 is occluded. Kind of mid P2 is back, and then we do see some flow in the tibials, but as those of us have taken these pictures before, that flow is very slow, and so it's not typically enough to supply the limb. We were able to cross this fairly easily with an 0-8 wire, and then get a little bit further down and do a distal injection to show that we are luminal. I always try to do that if I'm crossing CTOs to make sure that I didn't inadvertently cross in the wall and I'm not where I think I am. Of course, I use IVUS, and in this case, I used a 4 to 7 millimeter NAV6 Embo shield and a Hawk LX. And we get a pretty reasonable DA result here with inline flow now through the FemPop. Probably could have done more debulking in the popliteal, but the nice thing about the Serranator is that if you size it well, in this case, we used a 5 millimeter Serranator after IVUS, you really don't have to use DA ad nauseum because the Serranator is going to handle the rest of that lesion. And as you see, we actually took that 5 millimeter Serranator way back up into the external iliac artery. We followed that up with two 5 by 250 millimeter impact DCBs. And because she did have that lesion in the external iliac, we put just a simple 7 by 80 self-expanding stent. And with the exception of that iliac stent, we were able to get a very nice result with good inline flow and pretty reasonably healthy tibial outflow without leaving any metal behind in the FemPop segment, which is always a goal of mine. She did well. She had palpable pulses. She had no more rest pain. She discharged the following day, and she had complete resolution of her symptoms, and she did quite well after this.
That's also a great case. And that picture you showed is like a textbook a textbook type of picture of what a patient with dependent rubor, like you said, but those are also very often the people that have rest pain. It's usually in the toes, but if they have a wound, it's particularly tender. And you wonder like how many of these episodes were real cellulitis and how many were somebody looking at her foot going, oh my gosh, you need antibiotics,
You know,
something like that.
I think, I'm a cardiologist, so I came through internal medicine training first. And I think that it's a real hole in the training of internal medicine. And as a result, primary care docs. Vascular medicine is not well understood. And I think that that's something that I discuss with my colleagues all the time. How can we better train our internal medicine residents and general cardiology fellows so that they can spot this stuff, and hopefully direct the patient down the correct treatment pathway. And very often these guys get distracted and they end up down all sorts of strange treatment pathways which are not vascular.
Yeah. Also, yeah, that's a great case. And the other thing I'll just say, and this is my impression, I can't prove it, but my sense is when you get somebody whose ischemia is that profound, if they do get a wound, they progress quickly, typically. They have a lot of pain and it progresses quickly. Anyway, yeah, please go ahead.
Great. So here's another complicated patient. This is an 85-year-old gentleman who's a retired oral surgeon. He comes in with both legs cold, both legs with wounds, and really sort of a subacute, almost an ALI presentation more so than a CLI, although, all these things kind of live on a spectrum. So this was a couple of years ago, and the reason why I point out the timeline is because we treated one leg before we got the Serranator in the lab. We treated the next leg the day we got the Serranator in the lab. So his two legs are a nice case control study of what POBA versus Serranator can do. So in June of 2023, we treated the right leg, and then on June 4th, 2 days later, we treated the left leg with Serranator. Of note, 2 months later, he represented again, very similarly, with a CLI presentation of that right leg, while his left leg came back warm and looking great at that time. So I'll show you these images. So this is that right leg, which I didn't show the inflow, but suffice it to say the inflow to the popliteal is not that bad. But then the tibial vasculature, as you can see, is very challenging once you get below the knee. There's severe AT disease. The AT kind of peters out at the ankle. There's a subtotal lesion in the dorsalis, and the dorsalis does not really supply a complete loop. You get the sense in that first image that there are a medial and lateral plantar that are hibernating, but nothing really feeding them in line. This is actually an unusual case, but as I mentioned earlier, my threshold to go retrograde is pretty low. In these guys, the retrograde options are very challenging. It's not common that I do this, but every now and again, I'll go straight for the plantar. So in his case, I got medial plantar access in order to come retrograde, and then was able to externalize and treat the vessel. This was, I believe, laser atherectomy is part of my usual below the knee algorithm. And in this case, it was a plain old balloon angioplasty. And honestly, the end result is not too bad with straight line flow to the common plantar. You see both the medial and lateral filling nicely. And I thought he was going to do well. And of course, 2 days later, I was able to do the exact same thing in the other leg. He has mirror image disease, which these folks so often do. And this is our Serranator angioplasty result. And in my mind, there's no comparison. This is such a better pedal angiogram at the end of the case, with essentially a nearly complete arch, and that posterior tibial going into the common plantar just looks so plump. Anyway, suffice it to say, he came back 2 months later with the posterior tibial reoccluded in the right leg. Again, I had to do the same thing, getting medial plantar access. And the Serranator this time gave us a much more robust result, kind of similar to what the left leg that I just showed looked like. And he did great. And I ended up following him, every 3 to 6 months for the next couple of years. And he always came back with warm and pink toes, and there was no issue after this. So, this case for me proved that there is a massive difference between a plain old balloon angioplasty intervention versus a more definitive therapy, which I think the serration angioplasty is in this case.
It's also a very interesting case. His pattern of disease, like you said, is really similar on the two sides with the reconstitution of a DP and reconstitution of a medial and lateral. It's weird that it was so focalized to the ankle, in addition to his tibial, his longer segment tibial disease. And it's kind of interesting also. It's nice that you're able to get across it. Those are not always easy to cross. Sometimes just the and there are tricks. I don't know if, I always like to dorsiflex for trying to get across a common plantar occlusion, because that common plantar, especially if it's calcified, it takes a real kind of tortuous course when the foot is in the neutral or plantar flexed position. So a little dorsiflex, and then it's just the opposite for ATDP. And again, he's got another lesion there. It's kind of interesting, right behind where you'd say is the extensor retinaculum. And anyways, I don't know any other. The other thing that always worries me is when I see a reconstitution of the very distal common plantar, and then you've got the medial and lateral, and I'm worried like, geez, what if I can only get into one? I can't get into the other. Do you have any tricks for that? Do you
Well,
always go retrograde in that situation, or?
well, that's why, under this is a rather uncommon anatomy in my experience. Typically, there's a little bit more of a PT island. And if there is a more of a distal PT island, then that's where I'm going to stick, because exactly, you're right. I really want to preserve both the medial and lateral plantar. I'm not aware of any data of this, but it strikes me that the lateral plantar is probably the more important one, as it tends to go towards the plantar arch, and then, anastomose with the pedal loop up with the dorsalis. But yeah, I mean, with CLI, you do not want to be sacrificing vessels when you're down in the foot.
Yeah, makes sense.
Here's another interesting case. This is a gentleman we just treated a few weeks ago, actually. So 42-year-old guy, previously totally healthy, active. In October of this past year, developed sudden onset of pain and numbness of his right leg. He saw his PCP, who was diagnosed him with sciatica, and sent him to PT. This is kind of, another repetition of the theme that I think that, as internists, we're sometimes missing these important vascular diagnoses. In any event, the patient did not do better with PT, and he subsequently did worse. He started to have worse claudication, worse numbness. He noted that he actually had atrophy of his calf muscles, and he had very clear asymmetry between his right and left leg. And then in May of this past year, he stubbed his toe when he was moving a couch and developed a gangrenous wound. And he started to have, I didn't take a picture of the wound, unfortunately. I wish I had. But in any event, he saw a local vascular specialist who ordered a CT angio. The CT angio suggested a cutoff in the SFA, in the mid-to-distal SFA, with no clear reconstitution seen at all in the CT angiogram. The patient was then taken to the OBL for an angiogram, and very similarly was found to have a cutoff of the mid-to-distal SFA, and was told that he has no reconstitution. There's nothing that can be done endo. There's nothing that can be done with a distal bypass, and that essentially he can expect to have progression of his gangrene until he's going to need a BKA. He ended up bouncing around, seeing a couple other doctors, but eventually got referred to me for a second opinion. And, basically I offered him to try endo, being as I don't have the ability to do an open bypass. And, sometimes we get lucky. And basically said, I'll give it my best shot. And as you can probably imagine, his inflow is really healthy looking. He's got maybe a little bit of beating in his profunda, which I don't totally understand, but the rest of his vessels are totally smooth and pristine. Of course, there's a cutoff in the distal SFA just as it's starting to dive into Hunter's canal. And then you'll see on the initial angiography, really the only place where I can say with great confidence that I can name an artery here is down in the common plantar. So even though I just said a few minutes ago that this is fairly uncommon anatomy, here we've got two cases back to back that shows that it's, it's uncommon, but it certainly is not something we don't see every now and again. So, always start trying to cross antegrade. And because I didn't really know where I was going, because I had no calcium stripe to follow, and I wasn't able to see any obvious islands of reconstitution. I used IVUS to tell me if I was luminal in real time, and then a couple of distal injections with the crossing catheter. And so I was very clearly in a vascular structure, but I just did not know what to aim my equipment for. I mean, is this just a big collateral? Is that the posterior tibial? It's not clear to me. So yet again, we went ahead and got medial plantar access under digital roadmap. You see our 018 wire really just sails up the posterior tibial. It was a fairly quick work of then getting retrograde and externalizing the wire. We've got a 035 nav across, and with a little bit of patience, you can just wire the nav across from below. We ended up IVUSing, and I'll show you the IVUS in a moment. Essentially, this is just socked with chronic clot. The first thing I did was use a 6 French Jedi, and the first thing that everybody asks is, they still make those? And we had some left on the shelf, so I thought it would be worth a shot to see if I could get out any chronic clot. And we get a channel back, but really we're not able to get anything resembling an appropriate lumen. So I tried a little more with some DA, and same thing, we were just really not making any headway. And here's the IVUS. So we're down in the posterior tib. You can see we're luminal the entire way, but right as we get into the mid-PT, you just see dense chronic clot up into the tibioperineal trunk and now into the popliteal. And, the scale, you can tell that these are very large arteries. We're talking between 6 and 8 millimeters, depending where you are. So not technically meeting the definition of an aneurysm, but sort of ectatic. It was just clear to me that there was nothing I was going to do that was going to really get this clot out. So we ended up leaving him with TPA catheter. And this was admittedly a strange choice, because if we do believe that this was either an in situ thrombotic event or an embolic event, we're talking about 7 or 8 month old clot. So why would I think TPA is going to work in this case? Really, because it's a Hail Mary, because I don't have anything else to try. Interestingly enough, here's his angiogram the next morning. So I would encourage people who do this work to keep TPA in their toolbox, because you never know when it's going to work. And in this case, I couldn't have predicted it was going to work as well as it did, but it worked actually pretty well. There's a little bit of a lesion probably where I stuck that medial plantar, but the flow into the plantar branches is at least in line and clearly much better than it was before. Fairly straightforward work to use a 2 millimeter balloon to touch up that medial plantar. And then based on IVUS, took a 3.5 millimeter Serranator, treated the whole PT. And then again, based on IVUS, the POP and SFA were 7 millimeters. So I used a regular 7 millimeter balloon and followed that up with a 7 millimeter Ranger. And we were able to get, although there's still some chronic clot, and so we left him on triple therapy, beautiful inline flow now, revascularizing the foot. And he has done quite well. This is just about 2 weeks ago. So I just saw him in the office the other day. And, he had a palpable pulse. He says that this gangrenous wound healed, he says, within 48 hours. I have to take his word on that. I'm able to completely follow his plantar arteries through the foot, and his claudication is gone. He's got a 1 month duplex that's going to be pending. But, this was a real win. This was a guy who was told he had no options and was basically going to get a below the knee amp. And with some patience and with the Serranator angioplasty, we were able to revascularize his foot. So we were very pleased with this result.
Yeah, that's a great case. I'm not sure he would have kept the leg if you hadn't done lysis, because I don't know what else you can do in in a single setting that would have done that, remove that clot. What do you think the etiology is? I mean, I've seen this with a thrombosed popliteal aneurysm, but he doesn't really have that. And you don't usually see this, even with quotes arteriomegaly or, whatever. Like you said, they're big arteries, but you don't necessarily think they're going to shed thrombus into the runoff.
Yes, the short answer is I just don't know. We always think about occult atrial fib causing, cardioembolic stuff, or even a PFO where you could have a relatively small DVT that is not going to be clinically relevant as a pulmonary embolus, but it is clinically relevant as an arterial embolus. He does not have a PFO, and after a 2-week Holter monitor, he's got no atrial arrhythmia. So I just don't have an answer.
Yeah, good for you for chasing all that stuff down. And then, do you think in the long run he'll benefit from some additional, not just antiplatelet, but anticoagulation, or are you still thinking about that?
Yeah, so I think we're in a data-free zone. In the anticoagulation space, it seems that the NOACs are great, but that the low molecular weight heparin still has this pleiotropic anti-inflammatory effect. So I sent him home on aspirin, Plavix, and Lovenox, just because I wanted to be as aggressive as I could with his antithrombotic regimen. He has instructions to complete the Lovenox for 1 month and then go to triple therapy with Eliquis. He is seeing hematology for hypercoagulable workup as well.
Yeah.
So I can keep you posted when I get more information. But for now,
Yeah.
he seems to be doing pretty well.
No, I mean, this issue of the triple therapy keeps coming up. We were just this morning with my colleagues talking about a carotid case and what the risk of triple therapy. You just have to bubble wrap the patient for a couple of months, and then it's maybe a little safer. So I don't know, Mitri, if you have any opinion on triple therapy, but it always makes me worry, and I'm always looking for a way to do it shorter term, that kind of thing.
I love triple therapy. I mean, I think it's way easier to deal with, at least for as a vascular surgeon, it's way easier to deal with bleeding than it is with clot. So, especially these patients that they don't have like typically major atherosclerosis, or they have a lot of this soft plaque. I throw the kitchen sink at them because there's something that's making them clot or develop thrombus. Oftentimes we do not know what it is, so I throw everything at them, especially in that setting.
And do you do, when you do, Jon, for this guy, do you have him on a low dose or a regular dose anticoagulation and additional to his dual antiplatelet?
Yeah, that's a very good question. I think that the Compass and Voyager dosing rivaroxaban 2.5 twice a day is great for routine PAD patients. For a guy like him, I don't think he's a routine PAD patient, so I go full dose for him. Now, again, do I have data to back this up? I don't. This is, falls under expert opinion, I think.
Yeah, I would do the same.
Oh, go ahead. Go ahead. Sorry.
I echo that. I would do the exact same thing.
We have a question from one of our colleagues. Says, do you think once you have some inflow post TPA that it would make sense to reattempt thrombectomy, prior to angioplasty and such? Maybe you did. I don't know. How did you handle that?
I didn't show it. I did. I had the same result.
Yeah,
So
I
the
see.
funny
So
thing
you
is,
got out what you got out, and nothing else would
stuff was
come.
coming. Stuff was
Yeah.
coming, but it just felt
Okay.
like it was endless, and I could thrombectomize them all day, and it was just going to be a drop in the bucket.
Interesting. Okay. Do you have time? Is the last case a pretty quick one?
I have a last case. I don't know that I can do it in 5 minutes, so I will kind of leave it up to you if you think that we should
Well,
blaze
why
through
don't
it.
you throw it out there? We'll throw
Sure.
darts. How's that sound?
Sure. Yeah. So you mentioned the thrombosed popliteal aneurysms. That's basically this gentleman. So he's a 61-year-old vasculopath. He's had multiple CVAs. He's already had a carotid endarterectomy. He has CAD with stents. He was previously on anticoagulation, but he was having frequent falls, so his anticoagulation was stopped. He comes in with about 3 or 4 days of left leg pain, numbness, and weakness. He's got normal vitals, but his left foot is cool. He has some reduced sensation, his motor intact, and no Doppler signals. We get a duplex on him, which I'll just kind of interpret very quickly for you. You see that there's patent flow in the CFA and the profunda, and then it just looks like the SFA and POP are socked full of clot, and there's absolutely no signal down in the distal tibials. We get a focus on the left iliac here. So we see a aneurysmal common femoral, and then there's the bifurcation between the profunda and the SFA. The SFA is just gone. Even that profunda looks aneurysmal. And then when we get down behind the knee, you'll see this eggshell calcium that's pretty typical of these large popliteal aneurysms. And you guys who do vascular surgery know this even better than I do. These are very difficult patients to get back once they have completely thrombosed their leg. So we did bring them to the cath lab. He has this weird ectatic looking disease with probably mural thrombus throughout his profunda, and really no reconstitution until you see a little hibernating distal perineal artery in that third frame. we were able to identify the SFA under extravascular ultrasound and point a catheter and wire into it, because otherwise this was such an ambiguous cap, I wasn't sure where to poke. But this is a trick that I find is useful. If you do not know where your SFA is, just have somebody hold an ultrasound probe and then poke at that under ultrasound. And actually, the wire and catheter really flew down. I was able to do a distal injection there in that fourth frame, showing that I was luminal in that perineal artery. And so we left him on thrombolytics overnight, brought him back the next day, and we see again this ectatic, muralized thrombus throughout the SFA and pop, but it's open. So with IVUS guided decision making, we dropped some Viabon and covered the distal SFA and the pop aneurysm. And the end result was, we had inline flow to the perineal cross-collateralized with the distal AT. I was a little worried about how this covered stent was going to stay open with, kind of modest outflow at best. So I made the decision to bring it back the following day to open up the AT. So I tried, as always is the case, to cross antegrade. Again, I was not able to really point my equipment in the correct direction. So as is always the case, I have a low threshold to come retrograde. We were able to do, again, a reverse cart, and then I used a laser, and then I used a Serranator. And the final result there looks great. I did notice a few minutes later when we repeat the angiogram that the perineal outflow looks great and the AT is already starting to look kind of piddly. And the reason for that, when I recheck the IVUS, is I am deeply subintimal. And I think that the Serranator is great for reducing recoil, but it can't fix this problem. So I put a very short 38 millimeter coronary stent, and the end result is he has beautiful two-vessel runoff. And it turns out that this was actually a durable result, because I brought him back a few months later and I did a relook, and his AT looks wonderful. And he's got, a complete pedal-plantar loop that fills by that AT. And even a year later, he has triphasic signals all the way down into the dorsalis pedis with a completely normal ABI and TBI, and he did fantastically well.
Wow, that's pretty impressive, I got to say, because as you mentioned, I mean, usually I want better runoff, especially for a long segment Viabon in a popliteal aneurysm, and so maybe it was just perfect, the amount that you were able to provide with the recanalization. And he's one of these patients that it's good to know if he has a saphenous vein, because if his reconstruction then starts to fail, now that you've preserved his runoff, he would now be a candidate for, he would have a target for bypass. So that's pretty cool. Anyway, great case, very interesting. I think you both showed a lot of different uses for Serranator, and I mean, for me, it's become a go-to for a lot of things, but especially below the knee and in the foot when I go down that road. So, and it's fun to see all the different things that you did with it. We had some good questions from the audience. I think we're up to date on all our questions. So that's good. So I think what I'll do, since we're right on time at the top of the hour, I'll let you guys go. Consider, taking the rest of the day off, both of you. Unless you get a bad call from the ER or something. But thanks a lot for your time and all your hard work on taking care of the patients that you showed. So
Thank you so much.
Talk to you guys soon.
Okay.
All right.
Take care, guys.
Good night, everybody.